So those were kind of the main little intro things I'm going to talk about, but I wanted to start off just with a little bit of a question. So one of our topics today, and you may or may not have known, but it's talking about pediatric pain. So if you all knew beforehand, or even just hearing it now, kind of just what comes up for you when you think about that, and maybe decided to come because of that topic, or just hearing it now, kind of what kind of questions or thoughts come up around pediatric pain? There's no right or wrong answer.
One thing that has come up is shot anxiety, like vaccinations, and just wondering, like, I know that for my own kids, they use the shot blocker at their pediatrician's office and it does really great, but at the pediatrician's office that I work at, they don't. And so just wondering just if there's any research behind that.
Right. Yeah, I think just vaccinations comes up a lot for me when I think about it too. What about other folks? What, just to kind of prime us for our discussion later, what kind of things come up for you when we think about pediatric pain?
I sort of wonder how to effectively do it in integrated primary care too. And does it need more long-term type of therapy, or and like, are specific clinics better at managing that? Or is there outpatient providers that are better at managing that? Community providers? Just trying to figure out like where to send kids that are saying pain, and if there's no medical cause specifically, or like what to do in that case.
Yeah, I have a lot of those same questions too. I was really interested in the topic today because it's something I think that, you know, I think I could do a better job of helping with that, but I think it's probably one of those where it's in the clinic, and if I had a better protocol for it or knew more about it, I probably would get more of those handoffs. Like, I'm sure it's kind of like out there in the clinic, and it's not necessarily something that we have a specific kind of clinical pathway for right now, but I bet there would be the desire and the need for it if we marketed that as a specific service. So I'm excited to learn more about it myself. And so, yeah, please, like, you know, Rachel, Ali, Michelle, you know, feel free to help facilitate this discussion, because I think it's a great topic. Were there certain questions, Rachel, that you felt like you wanted to throw out to start us off with the conversation?
I guess I would just be curious if there have been people who have targeted chronic pain in primary care, what worked, maybe lessons learned if anyone has done this work, or maybe it's a reminder to start it, right?
I work at a FQHC in a rural community in Washington State, and so I work across the lifespan. And my background is more pediatrics, but I see everybody. So we do a chronic pain clinic or chronic pain monthly group for adults, and done lots of trainings and backgrounds in that area. And it just kind of speaks to that. I think we can kind of pull some things from the adult population to see they've done a ton of research on chronic pain and how to treat that in primary care. We do a quality of life group once a month, pre-COVID, of course. And it is aligned with when patients get their prescribed medications, so that they can come into the clinic once, get their medication. It's aligned with that really well, but also the thing that we found has been most helpful is that group support and having other group members are going through the same thing. And it just obviously speaks to the importance of, if we did this for kids, really having that parent support group and also the kid support group. And it's something that hasn't come up as much in our clinic in terms of, I think probably we don't screen for and don't recognize the need for more treatment for kids for chronic pain. It's much more the immunization pain and, getting blood work and all those kinds of things. But I think kind of hitting out, what's easiest for patients when they can come in, aligning it with what they're already going to be doing. And then also providing that support for, all the family members and getting that, peer support. I think has been most helpful.
Yeah, that's great. Thanks for sharing. I'm thinking about the support and the parent side of this is so big, especially when it comes to the impairment and recommendations that we may give in terms of, activities that the child can engage in, and not trying to foster, engagement back in their life, and not trying to foster avoidance. And that's a hard discussion sometimes to have. So I like that aspect of kind of that parent support piece and that group.
I'm curious to know what ages and peds you generally see chronic pain arise in. Like, is it just kind of like all over? I know with patients I've worked with, it's usually been more teens, like 16, 17, 18. I really haven't seen anyone younger unless they're dealing with like cancer or something, or diabetes, like gestational, or like type 1, or they're born with it. So I was just curious to see.
Normally, I think you're making a good point that often it is connected with an illness or an injury, right? Like orthopedics is an area that you'll see it. And so if it isn't, or even if it is, usually, at least what we see with the musculoskeletal pain, but I think friends in GI and neurology would say similar things about chronic headache and functional abdominal pain. They would say that we usually see it starting around adolescence. So there isn't great research out there to support that we do see it more in females, and there's some research out there to think that there's a hormonal component, but not too much. So, but that's at least for the musculoskeletal pain that I see, the chronic musculoskeletal pain, it tends to start around menses for the females. And that tends to be part of the perfect storm. We talk about the perfect storm with chronic pain. Like when it starts is usually an illness, an injury, and then some kind of stressor, 2 or more of those things happening at the same time. And as you can imagine, a lot of that happens in adolescence. So I think that is I don't know, I want to look up the stat now on the age, but it's definitely around adolescence.
Yeah, thank you. That makes me curious too about, when you have that age demographic, like what kind of group setting would be best, right? If you have like a bunch of teen girls, like what are they going to want to do? What would be most helpful? Patient that I had, it was female. She was 17, turned 18, and very athletic. She was actually modeling, like all sorts of stuff. And then she just got hit with this, like it started with her knees, and then it just like went all over. She could barely walk, and she was always in therapy. Like she had this like water swim therapy with PT. I can't remember everything else, but even just going to the doctor was exhausting. So it's just like adding one more thing just made her want to blow. So it's just like, how do you get, like, I guess, buy-in for a group when it's like one more medical appointment? It's just like, I understand you don't want to come see again. So.
Michelle or others, like I was interested in what your reaction to that article would be. If Michelle or other folks that have expertise in treating pain, even if it's not in the primary care setting, like, does that seem feasible? Like what this article is recommending in terms of the brief interventions, or how can folks who do work in primary care, like what words of wisdom, I guess, would you have for us in terms of, how to do a better job at addressing pain within primary care setting, especially if you're working in a brief model? Is it just a matter of like getting more education around it, or do you feel like there are kind of like structural barriers to addressing it because of the setting? I know you were saying like you were finding that it's kind of hard to make that transition or that decision about the brief visits versus the ones that you refer out. So I just was trying to think through how can we I feel like the research article is a great model to like set us up for how to have this conversation of like, how do we do better, you know, in addressing this in the settings that we're working in.
I'm happy to take it, but also don't have to. This may sound too simple, but I'm thinking about the like PEDS residents in primary care that I spend some time with. And I think the biggest thing that comes up is not asking about it. I mean, that sounds so simple, but I think if we just start there about talking with medical teams about asking about different types of pain, but also around psychosocial stressors, right? That makes a big difference. And with our behavioral health providers, making sure they're asking about somatic symptoms. And especially when the red flags come up, which maybe we don't know the red flags well enough, those risk factors for chronic pain, that would be another thing to learn more about. Like when I hear about a high achiever who says that she's fine, it's a female who's an adolescent, who is in lots of activities, I want to ask about somatic symptoms. And I mean, I don't know that that's something that is, you know, trained in PEDS, that there are these risk factors that set kids up for chronic pain, and we should be asking about them.
I listened to a podcast recently. I don't know if anyone listens to the Z-Dog MD podcast. He's had some really good ones, and he had a fantastic guest. It was Rachel Zoffness who talked about chronic pain. I thought I could listen to that 5 times. Like, it was just great. So many good takeaways from that podcast, just how she talks about pain. And sometimes I think even for, you know, we see kids with chronic headaches or GI symptoms, like I think to offer that psychosocial model of pain and to help people understand more about how it works. I think that is something we can offer in a brief visit, and even just a warm handoff to sort of help explain, so people understand pain, that, you know, the it's all in my head and I'm not crazy, and, you know, just sort of dispelling some of those myths for patients.
I really like that you said that, and Michelle, you too, in thinking a little bit about how do we make sure that this is on the primary care providers' minds as well. And so instead of, I think the challenges that I have, and I did one of my specialties during internship was medically unexplained physical symptoms, but it was in a hospital-based setting. So we were involved in rehab and HEMOC and all kinds of different areas in the hospital setting. But one of the things that I think about continually is, when does the behavioral health consultant, no matter what setting you're in, get involved, and how important that is. And so the model that we set up there that I've really tried to implement here in my PEDS primary care practices at the beginning. Right? So when we're asking about pain, that this is part of how we take care of pain, is by having this person who's a part of our team be a part of this conversation. And so I think that helps to dispel this "it's in your head" piece. If we're there at the same time that they're running their tests, at the same time that they're working up the labs, or whatever further medical assessment needs to be done, if we are there part of that discussion and we're starting to talk about that biopsychosocial piece from there, gosh, those kids do better. And it's because they have that perspective from the onset. And so I think that, you know, the things that Zoffness talks about, I also really like Brian Carter's CHIRP model. Like, I think that there's a lot there that can really be beneficial, but I really think the timing is so imperative.
That's a really good point. And so that it's not, so that it's just assumed like this is just part of the care you receive. Allie or Sarah, like, or Michelle or anybody else, like, do you all have examples of some sample language that you use kind of in those initial conversations to, I guess, lower stigma around your involvement? Or, you know, I think sometimes whenever I meet with people, it's, you know, they're a new patient at the clinic and it's already like this huge issue, and they, you know, if you're not careful, perceive behavioral health involvement as invalidating, or like you're not actually taking my symptoms seriously, or if this is a medical thing. So I'm just wondering what they found, kind of example language helps, you know, to explain your role in that kind of setting. when you're doing that introduction.
I think that's the luxury of being in a specialty care center too. At least for me. And my team played around with a couple of different words to describe me. So there was both. So that's the other important piece, right? Is to talk with your medical team about how they present who you are and how they talk about it. And I know one of the rheumatologists really, we went back and forth between counselor, pain psychologist, health psychologist. You're all having these conversations too. And they ended up liking health psychologist and talking. And so they start the conversation around the mind-body connection and about health and wellness. And then they chose the term for me. I wanted them to pick a term that fit them, that they could say most comfortably. And then when I come in, I spend time talking about what pain is and how the brain works and how the nervous system works. And it's a lot of education. And the importance of that there's a medical team. You have a team around you. It's, I'm not alone. We all work together. We think together, and we're all going to care for you together. So that's just some of the language, but the education is really key, I think. There's a lot of great videos and clips and resources out there for that.
Yeah, I would agree with Michelle. I think that the team language is super important. I also think that if you can be there from the beginning when they're meeting their insert specialty doc here, I think that that's really important. So whenever we have a kid who's coming in with pain, if I can do that as a shared care versus a warm handoff, I think it's more successful. It really shows and embodies that team mentality. And then I think exactly what Michelle talked about, I would say, honestly, that's what I end up doing a majority of the time, is providing that education. And I think if I can do that with the doc in the room, that helps, right? It reinforces that we're all a team and working together. It also, I think, surprises them that information is coming from you as opposed from their physician. And so I think that helps unite that we are viewing this as a body process, as opposed to here's all your psychosocial concerns that this person's going to manage, and here are the physical concerns that this person's going to manage. So if we can do that together, I think that just provides better, well-rounded care. And then I think they're more receptive to the things that we're talking about, which for me is mostly functioning.
And then it's really fun when you catch your pediatricians using your language with future patients. That's the best. They're like,
the best.
Yay. Mm-hmm. Or the patient's telling you, well, the doctor told me this, and it's, this stuff that you had taught them. Yeah, and it comes back around.
Yeah. And I think it's important for the families to see us, right? Like I think about what for all of our pain patients, it's never just the nurse practitioner from rheumatology or myself. We always try to do those together. And they notice when I'm like, Barb, what do you think about that? And then Barb turns to me and is like, Michelle, can you add to that? Right. And they see that happening right in front of them. And that shows them, oh, wait, we do need both. We need both of them. They need each other. So that's key. And having just in case this hasn't been said, having the family be part of that education and those conversations is really important, because I tend to see with the adolescents that the families are kicked out of the room, not, you know what I mean? And then all this is done with the adolescent, but then they go home, right? And the pain is reinforced in ways that the family doesn't mean to. They just don't know how to be at home with the patients with pain, so.
Or Rosa or Noelle, Beth, any questions or comments that you had? I want to make sure we were able to get everybody's input if you want to.
No, thanks for including. I'm just kind of soaking it all in right now. I had sent a message to Michelle earlier. I'm doing a rotation in the rheumatology. So I'm with the rheum team. So I think like I'm a couple weeks in, so this is like very relevant and very, very useful for me so far. Yeah.
Nothing for me, but this is great to hear about. So thank you, everyone.
The only other thing that I was wondering about is we talked a lot about kind of these chronic pain pieces. And I think that there's, I don't know, like 17 or 18 layers to pain in which you can get involved in primary care. And I think I think Kelly, you mentioned it maybe right when we started about immunizations. And I think that's huge. And that's a big part of my practice too. And so I just wanted to, I didn't want to not acknowledge that as we were having this conversation, even though it could probably be its own talk.
That might be a good one, honestly.
Yeah.
Allie, what are ways that, do you all as a whole clinic kind of have a way that you address these immunizations, or do you feel like it's just like a BHC specific intervention? Because I know with us, I think to change the way, it would have to be to change the way that nurses are educated, change the way it has to, you have to change everything if you were to really have kind of a trauma-informed way of addressing this. And so I'm just wondering what kind of, in the last few minutes, what creative things folks have done to help with that.
I'm sure lots of people have done lots of amazing things, so I want to hear everybody else's too. I think you hit the nail right on the head, Matthew, which is this is a team approach. And so whenever we were developing how are we going to manage immunizations and offer comfort measures consistently across the board, and that depends on age, and that can include things like how you hold the child when it's in infancy, all the way up to coping strategies or needle phobia strategies as a child is older. And really, it's exactly what you talked about. It's how do we get representatives from everyone in the room. So MA staff, nursing staff, how are the docs talking about immunizations? Are they using the same language? And really trying to get education out to everyone has been a huge, huge piece. So the consistency, I think, is key.
I'll say the nursing from our institution led something that they were a couple of years ago, so it was timely. They originally were calling it the Painless Initiative. Like, no, that's really not very helpful at all. So now the posters say less pain.
That's probably more accurate.
Yes, but we had to talk about that, and it was definitely a place to have a behavioral health specialist insert themselves and say, no, and to share some of the data of what we know around management of acute pain and immunizations. And it's definitely a place for us to have a seat at the table of these conversations. But that, it came all through nursing, and it was a huge thing when our institution did it a couple of years ago. And we now have like the spray and LMX cream, Emma, to offer patients, and all of the staff, yes, know that these things are available. But it was a big undertaking. Well worth it. Definitely a huge patient satisfier.
I think we're about running out of time, but again, if you're interested in leading a topic on the facilitated discussion or doing our kind of quick notes presentations, or what your model is, feel free to shoot us an email, and we'd be happy to incorporate you into the agenda for the future visits. And I just appreciate you all showing up and having a conversation and sharing your knowledge. I mean, this is one of the, I think meeting with you all is one of the bright spots of my month, to be with similar people who are going through kind of the same stuff and have the same struggles and are trying to make this kind of stuff work. So I'm just appreciative to all you all for kind of continuing to share your knowledge. If you have any questions about the email or want to be on the listserv, you can email Jackie, who's on the call, and we will meet again next month. And, it might be interesting if you have a really, whether it's around vaccinations or chronic pain or any type of pain, if you have some really nice resources that you use or approaches that you've mentioned, maybe shoot Michelle an email with those. And Michelle, if you have kind of the top resources you feel like are helpful, maybe we could distribute that out as just a listserv email, kind of with a little bit of a summary of those. So if you do have things that you would want to share with the group, or kind of want that compiled list, even if it's just a few things, that might be something that we could send out, if that's okay with you, Michelle.
Yeah, I was gonna say that too. Feel free to send me whatever you have, or if you're looking for something, and then I can put together something.
Right. Anything else before we end for today? All right. Well, you all have a great month, and I'll see you next month.
Thanks, everyone. Have a great day.
Bye.
I